Well, let's now look at other non-uterine causes of pelvic pain, part 2. The fallopian tubes can be a cause of pelvic pain. Inflammation, such as salpingitis or sexually transmitted diseases or pelvic inflammatory disease, either low-grade inflammation or severe inflammation, hydrosalpinx, ectopic, tubal torsion, paratubal cyst torsion, and neoplasm. All of these can be tubal causes of pelvic pain. So let's look at low-grade salpingitis. I think this is not an uncommon cause of pelvic pain. It presents with chronic pain, focal tenderness. They may have dyspareunia. It's a low-grade inflammation, may have absolutely no fevers, chill, or discharge, but there's focal tenderness using the endovaginal probe, but the fallopian tube actually looks quite normal. If in fact this is real, and there are some patients for sure who have this, a 10-day course of doxycycline for the patient and her partner or similar antibiotic therapy may in fact result in a resolution of this low-grade salpingitis. You have to look with ultrasound at the proximal end of the fallopian tube seen here. And so here in this patient, left lower quadrant pain, tenderness, she does have a previous history of PID. And when we looked in the axial view at the area where the fallopian tube arises, and when you push right there, that's in fact where she was experiencing her tenderness and her pain. And so I would suggest that in fact this patient had a low-grade salpingitis. Obviously, in patients who have fever, increased white count, may have discharge, they have fluid in the posterior cul-de-sac, they have large tubovarian masses. I mean, this is obviously tubovarian abscess and not that difficult to make the diagnosis. You put them on IV antibiotics, and 3 weeks later, the uterus is back approaching normal. So obviously, severe PID with tubovarian abscess is clearly a cause of pelvic pain. It's a most unusual patient. This patient has had 1 month of pelvic pain. She had a previous hysterectomy, but they've left in that right fallopian tube, and it's filled and it's distended with fluid. And what's interesting is that she had the discomfort while this fallopian tube, obviously still innervated, was contracting quite by itself. The fluid was enclosed, and so obviously not going anywhere. So she had spontaneous contraction of her in vivo fallopian tube. Here's another patient who had pelvic pain, and on CT examination years ago, they saw this cystic mass, said it was an ovarian cyst, but on ultrasound, we saw an oblong mass. We aspirated the fluid and got tubal cells. So this was actually, and when you go back to the history and the pathology reports, they had left in her left fallopian tube. So I drained it, and then the cyst or the distended fallopian tube came back, and in fact the pain did not particularly abate following the drainage. Ectopic pregnancy, such as here, again, is obviously in the right clinical situation a cause of pelvic pain. Here's a non-gravid uterus in a patient who is 8 weeks pregnant. Echogenic material in the posterior cul-de-sac, which is blood, corpus luteum cyst in the right ovary, and on the left she has this echogenic mass, on the right, inferior to the right ovary, echogenic mass, which was a hematosalpinx and an ectopic pregnancy. When they removed the uterus, you could see the ectopic within the tube and actually also see the chorionic villi situated in the tube, again, making the diagnosis of an ectopic pregnancy. So ectopic is another cause of pelvic pain. Here's a patient who had an empty uterus. She was 12 weeks pregnant, 18 years old, her first pregnancy, big distended arcuate veins, and in fact in the right cornua she had this irregular cystic mass. So she had an interstitial pregnancy, a very low beta, interstitial cornual ectopic in the right cornua. Clinically stable, but they decided to operate nonetheless. On sweeping through the endometrial canal, you can see in that right adnexa, very, very vascular mass situated in the right cornual region. This was a number of years ago, and so they decided to operate, and there I am standing at the patient's head, and you can see this mass. They put a rubber tube around the lower uterine segment to occlude the vasculature. They then dissected off the mass, and on pathology you can see this irregular gestational sac. So this was an early pregnancy failure in a cornual location. Obviously the management currently, because the beta was dropping, because she was clinically well, they would have opted for observation of this patient rather than for surgery. They sewed her up, and she did well following. Whether or not she would be a candidate for future pregnancies is yet to be decided. We always look in the upper abdomen for the accumulation of blood to give a sense of how much blood is in the abdomen in patients who have suspected ectopic pregnancy. Here's another patient who has had a CT scan showed a mass following 2 months ago following an incident of pain, never had a pregnancy. You can see the normal left ovary, and in the right adnexa, we thought this was right ovary. She has a big irregular mass with some solid components. You can see it's avascular, the solid components. And in fact, when you sweep through it, there's a jelly-like consistency to this solid component. We weren't sure exactly what it was, but we were concerned that this was an ovarian mass. The other pictures, you can see the what appeared to be some calcification in the septum of the mass, a somewhat thickened septum, some nodules. So we were concerned that this might, in fact, even be a neoplasm. Well, here you can see at laparoscopy, there was the mass with adhesions around it. There was the right normal ovary. I must admit that we sort of got sidetracked by looking at the mass and we missed the ovary. But that mass, in fact, had a stalk that was twisted, and this, in fact, was a hydrosalpinx with torsion, and that's what the mass was. So to remove it, what they did was they burned through the stalk and then removed the hydrosalpinx, and the patient has gone on now to have several pregnancies following that. So here you can see the removal or the bisection of the stalk. Then they removed all of the adhesions. And here a little video during the surgery of them removing the adhesions. They put in a bag into the peritoneal cavity, put the hydrosalpinx within the bag, perforated it, got the fluid out, and then removed the remnants, and here you can see the remnants of that distended fallopian tube. So, and she recovered well. Para-ovarian cysts or paratubal cysts, small thin-walled cysts, remnants of the Wolffian duct, easily missed or mistaken for ovarian cysts. To confirm it, just make sure that you can separate it. On endovaginal examination, here is a little bit of free fluid with the thin-walled cyst. There's the fallopian tube, and in fact, here is the specimen, that small paratubal fallopian cyst. And these are remnants from the Mullerian duct. They can be cysts in the lateral wall of the vagina, the Gartner duct, along the uterus, or along the tube and ovary. Fallopian tube neoplasms are very uncommon, 0.2 to 0.5% of female pelvic tumors, usually papillary serous cystadenocarcinoma. They can present with pelvic pain in 30 to 50%, as a mass in 12 to 61%, or with some discharge. But the classic symptoms are only seen in about 15% of patients. They are similar to ovarian cancer, need a hysterectomy and chemotherapy. Here's a 62-year-old patient with some free fluid, retroverted uterus, this oblong mass in the left adnexum. On sagittal view, it has some vascularity within it, and we were quite concerned that this mass actually had a sausage shape and was in the left fallopian tube, so wondered, in fact, whether this was a fallopian tube neoplasm. At surgery, you can see the papillary mass extending through the fimbriated end of the tube. It was serous papillary cystadenocarcinoma.